you. Which feels easier, to the right or to the left? Okay, so the right went a bit deeper. So now the patient says, okay, so he knows his right is more mobile. So now we turn. So you're going to stand in this gap because I don't want you to get your head on the bed. And I'll come back a bit because I'm standing off the stage. No, come back, we're not ready. Lift your shirt. So. Can you all see my fingers? Are you happy? These fingers are extending across the ilium. All right, so lift your right knee up. No, right hand side. Lift. Can you see how my right finger has dropped down?
Yes.
And bring your right leg down. Lift your left leg up. What did you all see? No movement on the left. Left leg down. Lift your right leg up. Is downward slide. Right leg down. Left leg up. Bit of movement, but not much. The other way of looking at this is I can put my one finger there, my other finger here on the ilium, on the ischial tuberosity. So if he lifts, this finger should move laterally. Does that all make sense to you guys? So lift your left leg again, and down. So we are getting a bit of movement, but it's not completely locked. So now we've assessed that, he's got to do a flexion technique. So I theoretically should be watching from here, but I need you guys to see. Bend forward, as if you're going to touch your toes. No, bend forward. Forward flexion. I just need to check. I don't know if you can all see that. My left finger's actually stayed behind a bit, and my right finger's gone forward. So I'm getting a contradictory result here. You might get your right and right there. Okay, come back up. Come over, lie down on your back. So what have we seen? We've seen a funny moving left joint. Something is happening there that we don't know. So the right side has movement when he's doing the Gillet or he's flexing, but on the left side, on the Gillet test, there was no movement, but on the flexion, there was excessive movement. So I don't know if he's got lumbar spasm or tight facet joints or block joints, but that's where we have to still go back into a full spinal exam as well. But this is a limited workshop, so we're going to stick just to the SI, and hopefully we can treat it perfectly. All right, bend both your knees. Lift your bum up into the air and down. And we're going to straighten out. And we look at leg length, and this is the same, right leg longer than left. But this confirms my theory that I've got. I find all people tend to go out in the same way. And I don't know why. I'm still asking that question. So I expect to see on his pelvis the left side rotated posteriorly and the right side rotated anteriorly. And that's exactly what I'm seeing. Left posterior, right anterior. Okay, but we haven't finished testing. Let's get you onto your tummy. So, fingers on those little dimples. They are equal. No, they're not. The right is deep. The left is a bit more superficial. Come up onto your elbows, please. What did I say? The right was deep and the left superficial. That's still the case. So what does that tell me? That is a locked out SI joint. We call it an upslip. That changes the treatment again. So now we've got to unlock the SI. So the textbook would tell me I've got to do a longitudinal manip of the leg. What did I say that I don't like doing? So like that for me. Turn your head to the side. If you're going to do this manipulation, you have to be trained to do it. You've got to rotate the leg internally, take up the tension, and then ask the patient to cough and give a big manip. I've stopped doing that. I only use those if my corrections never ever work. Then I go back to the old techniques. So he came up, left superficial, right deep. Correct. What did I say? I didn't hear that. We'll speak together. Okay. So He was sitting in that position. He came up and it stayed in that position. So what does that tell me? Which axis are we dealing on? So he's now right on right. Okay. So how are we going to treat that? So we still got to assess his rotation. We haven't finished. So now I'm looking at his rotation and it actually looks okay. There's no rotation there. So theoretically, we saw that his pelvis was rotated. What am I going to do? I'm going to use the block technique, not the Barry Getz technique, because I never made this up. The chiropractor showed me this once. And I'm actually going to mobilize this just for a second. So what am I doing is I'm just mobilizing away from these towels, just to actually treat it for a bit. What grade am I pushing with? Grade 1, 2, 3, or 4? This is a grade 3 mobilization. What is a grade 3 mobilization? I'm going into resistance. Okay. I'm not doing that. There's a grade 1. Feel the difference. Grade 2 is a large amplitude, no resistance movement. A grade 3 is I'm going into resistance. A grade 4 is at the end of range with the mobilization. You feel the difference, yeah? Okay. Now I can feel all his tightness. So he's actually quite a bit of space in his back. But let's treat it a bit. Let's get it sorted.
Up to the tissue.
Okay, so let's assume I'm going to fast forward. I've treated him. I've done everything. Turn onto your back. I'm going to correct his pelvis. Hopefully his pelvis will not correct and I'll have to go all the way back to his piriformis, back to the individual techniques. So, bring both your knees. Bum up and down. And down. Straighten out the legs. The pelvis is still rotated. Left is posterior, right is anterior. So, we'll do that muscle energy technique. Come closer towards me. Hold that position. Do not let me push you down. So I've locked back opposite or the contralateral pelvis. You ready? I'm going to start pushing. Whenever you're ready, you can start pushing. Are you pushing? Lift. Lift your leg. Lift. Whenever you're ready, lift. And relax. Okay. Lift again. And relax. And again. Good. Okay, shift to the right of the bed. Start pushing. Okay, so there he lost his lordosis. Do not lift up your tailbone. Keep an arch. Push. Foot must go straight down onto the bed. There we go. How does that feel? Better. And relax. You've got proper force now. You can feel it. Push again. Now he's pushing quite hard. Now I'm actually losing my footing. So I'm going to start holding the bed now. And relax. This is why I'm here. And again. And relax. So let's check that rotation. Lift your bum up and down. Down. Straighten out your legs. So it has corrected, but it's still not perfect. Come and see what I'm showing. This is the gent who asked me an awesome question. So, you can't stand there because the camera can't see. You've got to come around. Which finger is higher, which finger is lower? Talking to my mic. Are you laughing? Why are you all embarrassed? Stand still. the microphone. Okay, so the right is posterior, the left is anterior. But is that what you saw? So it's actually not correcting. So now I've got to use piriformis. Because I've got to try and release that sacrum somehow. Piriformis attaches from the ventral surface, lateral to the alar, and inserts into the greater trochanter. Alright, so we saw a right on right. So here's, oops, sorry. So you're going to lie for me on your right hand side. Face the audience. Who came to my very first lecture where I said sometimes you get patient suffering, cognitive impairment. Alright, so to work the piriformis on the right side, I want you to put your right arm behind your back now. Behind your body. So you're going to have to pick up your body. Okay, well, it's not funny because every patient gets this wrong, and I can guarantee you all of you will get this wrong as well. And then this arm hangs off the bed. And here's my independent observer. You don't have to hold it. So what am I going to do? I would probably be on a chair now. I'm going to take the left leg and just position it on the bed comfortably. The right leg is hanging off that bed. How weird does this all look? But I've got his entire thigh supported by the bed. Hold your ankle in this position. Do not let me move you. Hold. Do you feel your bum working? Not working in that way. Guys, I know it's Saturday. Keep it clean, eh? And relax. And again. And relax. And again. And relax. Turn onto your back. Bend both your knees. Bend your knees. Lift your bum into the air. Down. You happy with the leg length? Are you happy with the rotation of the pelvis now? Not bad. Come stand up, let's repeat the tests. And then I'm going to show you a cheat, what I call a cheat sheet, that should fix 99% of SI joints. So, this is a cheat sheet. It's quite good. Come walk towards me. We're not dancing here. Bollywood is tonight. The Royal dinner.
We are not dancing.
Alright, I want you to lift your right knee up to hip height. Good, excellent movement, and down. Left leg. Excellent, and down. Left again. Excellent, and down. Right. I mix it up so the patient does get confused. Okay. Bend forward, touch your toes. Oh, miraculous, they're both moving together. But don't take my word for it. Come and observe. Okay, bend forward. Bend forward. So what we were seeing before is a hypermobile right side. And they move it equally. So now come stand up, face the audience again. And do your side flexion. Remember, to his right was harder. Okay, other way. How does that feel? How does your discomfort feel? How was your discomfort? You said you were a bit sore. Move around, tell me if it's okay. And we haven't heard you. Alright, so we're now 5:15 and we theoretically finished. Do you want to go on? because I can show you my cheat sheets on how I do this. I don't go through all of this all the time. So for some bizarre reason, if you drive your car on the right-hand side of the road, in other words, the driver